Kia ora koutou, and welcome to tonight's Goodfellow webinar. Te Whatu Ora presents Te Tiri Whakāro Sharing Knowledge, a series of webinars to support primary care. My name is Pulasti, and I'll be your facilitator for tonight. Professor Ben Wheeler will provide an update on vitamin D use in pregnancy, infants, and children. Dr. Guy Melrose will discuss chest and pelvic injuries commonly seen in the elderly. And we will finish with a clinical update by Dr. Christine McIntosh. Now, a bit more about our speakers. So Professor Ben Wheeler is a pediatric endocrinologist working in the southern region. His clinical and research interests include vitamin D and bone health, as well as the use of technology in diabetes in youth and emerging adults. Dr. Guy Melrose is an urgent care physician who works clinically in Tauranga. He is the Director of Professional Development for the Royal New Zealand College of Urgent Care and a Professional Teaching Fellow at the University of Auckland. And Dr. Christine McIntosh is the Regional Clinical Director, Primary and Community Care for Health New Zealand. These Te Whatu Ora sessions run on the last Tuesday of every month, and the next session will be on May 27th. More details are available on our website. So without further ado, I'll hand over to Ben, our first speaker.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Greetings to you all. Nice to be here with you this evening. Hopefully, you'll have all heard and thought a lot about vitamin D over the years. And this session really is just to provide an update around the new Ministry of Health guidelines, particularly relevant to pregnancy, infancy, and childhood. So hopefully that's helpful to you. Certainly, we're very keen to get a bit more of a message out there around this. I've got some cases. I will just go over rickets, which we're seeing quite a bit of at the moment. And if we can use the new guideline for vitamin D supplementation, we should substantially reduce that. And I'll give some specific situations around the national guideline, lab testing, and discussing around children, rickets, pregnancy. And I'm sure you'll have some questions. So just a recent case, 9-month-old child of Pacific ethnicity, breastfeeding, just starting to have some solids, no supplements of any kind to mum or baby at any point through the pregnancy. And they present with 2 generalized tonic-clonic convulsions, and as part of the workup for that, are found to have a calcium of 1.4, so that's pretty low, normal range is 2.2 and above. A phosphate that's low at 0.9, an elevated parathyroid hormone, high ALP, unrecordable vitamin D, which is quite common here in the south, microcytic anemia, and of course they needed a significant multi-day admission, IV calcium, calcitriol, and quite a lot of drama and trauma to all involved. And then I've got another case. This is an adult patient, Indian ethnicity, dark skin. So second pregnancy, but again, no vitamin D given at all during her antenatal care. And again, hopefully all of you will be aware that she should have been given vitamin D. She had aches and pains right throughout her pregnancy. She delivers preterm, a 35-week infant, and is breastfeeding. But on day 10, Mrs. S, so the adult person involved in this case, starts having convulsions on the postnatal ward. She's got a calcium of 1.6, low phosphate, unrecordable vitamin D, sky-high PTH, and then we're called and we measure the infant's calcium and are also hypercalcemic in NICU. So again, all of these, I realise, are very preventable situations. So just highlighting, this is the classic frayed, splayed epiphyses that we see in rickets. And again, the key thing is phosphate with these. So as PTH goes up, we retain calcium in the kidney, but we pee out phosphate. And as phosphate goes low, phosphate controls apoptosis and these beautiful chondrocytes here that we see in the growth plate. So without regulated apoptosis with phosphate, we get these hypertrophic chondrocytes, and we get the splaying, the fraying, and the very abnormal picture that we see there. So it's all about phosphate really, and that's driven often by PTH being up. This is a description taken from a paper in 2015 highlighting rickets in New Zealand children, just highlighting to you all that the median age of presentation is 1.4 years, although we saw cases out to 11 years. The maternal ethnicity in 70% of the cases was Indian, South Asian, or African, but we saw it across the ethnic spectrum. And almost all were exclusively breastfeeding. And that's important because formula carries vitamin D and breast milk unfortunately doesn't. Skin color, over 80% were intermediate or dark in color. And you can see the image at the bottom there. You can see in April, we're at the low point in rickets. We're just coming out of summer. We've got our highest stores of vitamin D, 25-hydroxyvitamin D. But you can see from July, it steadily ramps up. In October, we see November, we see the real peak of rickets through until December, January, where again UV picks up again and it ebbs away. So as a screening test, just remember ALP is a wonderful screen for increased bone turnover, and it's present in 99% of cases of osteomalacia in adults and rickets in children. Calcium, phosphate, magnesium. If phosphate is down, it immediately suggests that PTH must be up. And a wrist X-ray, particularly if the phosphate's low or the ALP is high, is very helpful in identifying ricket changes. But you can get biochemical rickety changes with high ALP and biochemistry only, particularly in the very young. Sometimes the change is biochemically happening so quick that bone doesn't even have time to mobilize. And again, optional at that point, but if we're seeing a high ALP or issues with phosphate, we would measure a vitamin D, parathyroid hormone. And just remember other nutritional factors. Often in these children, we see a whole range of nutritional issues, often around iron deficiency and other things. So it's definitely worth measuring at that point. And this is a good place just to come into the new national guideline, which has got some significant changes. Hopefully you all know about it, but I have a feeling that we haven't communicated this particularly well. So here's the new guideline here from Te Whatu Ora. It came out in 2024, and it's particularly focused on infancy and pregnancy. So just here, note the key recommendation there, new recommendation for infants. Vitamin D supplementation should be considered for all infants who are exclusively or partially breastfed. It should be initiated as soon as practical, but at minimum by age 4. So again, in primary care, often you're getting people from 6 weeks on. We should be screening with those immunizations that they're on, and it should continue until at least 1 year, and in high-risk individuals for longer. Just noting there that breast milk alone is not an adequate source of vitamin D, even in mothers who are on quite high doses. If you're on a litre of formula a day, you'll be getting a similar dose to the drop of Perea vitamin D that we have available through Pharmac. So again, infants who are on a litre or more of formula don't need additional supplementation. And you can see here the risk factors for vitamin D deficiency: people with naturally very dark skin, particularly South Asian, African, Middle Eastern; people with minimal sun exposure due to religious or cultural or medical reasons; people living in the southern regions of New Zealand. I'll show you a UV map soon, and you'll realise that the southern regions are pretty much everywhere south of Auckland; people living in aged residential care; people with reduced mobility; older people admitted to hospital; people with hip fracture; and people with medical conditions or on medications that interfere with vitamin D or calcium metabolism, particularly anticonvulsants and rifampicin. So again, just highlighting this nice picture here from Niwa, and you can see here in winter, you can see the green zones are low UV index and the red and the yellow are high UV index. And you can see it's pretty much only Bay of Plenty and North that even gets vaguely even to UV index of 2 in the middle of winter. They don't even get to above that. And so it's really Bay of Plenty, Auckland South that's going to be important when we're thinking about this. But particularly if you've got a naturally dark skin tone, you're living south of Auckland, and you spend limited time outdoors, any of those risk factors will qualify you for vitamin D in pregnancy. But of course, all infants, if they're breastfeeding or partially breastfed, will require supplementation. And the historical data there at the bottom just again highlights that 70% of the children we see belong to ethnicities that are South Asian, African, or Middle Eastern. And there are a whole range of factors that influence this, including skin tone, but also cultural views on sun exposure. And again here, sorry, my slides are right in the top, so I can't see the top. But infant risk factors, maternal risk factors for vitamin D deficiency and insufficiency. Testing, remember we're not interested in testing asymptomatic pregnant people or infants just for looking for vitamin D insufficiency. You should just be supplementing them. But testing may be appropriate for pregnant people with a known history of vitamin D deficiency, people who are pregnant with unexpected raised alkaline phosphatase or low calciums or phosphates. And you can see the other things there. But any infant who presents with any risk factor for rickets, we could consider that, particularly if they have a raised serum alkaline phosphatase. In pregnancy, the recommendation is to offer vitamin D supplementation during pregnancy if they have any of those risk factors above. So just one or more of those. We have the option of the Perea vitamin D drops, just 1 or 2 a day. But I'll show you a slide early on. If they were on the 50,000 international monthly cholecalciferol, while we don't have a lot of safety data on that, it's been used, countlessly over the years gone by. And our general advice at this point is to consider just continue running them on the same preparation they're already on, rather than fiddling around with a daily preparation. Ideally, in pregnancy, if it didn't cost $1 a day, people would be on a multivitamin such as Elevit or something like that. So people who are on that don't need that. Infancy, offer to prescribe vitamin D supplements for all exclusively or partially breastfed babies. And the supplementation should begin as soon as possible. 1 drop of the Perea liquid contains 400 international units of cholecalciferol. And just remember those risk factors there in pregnancy, and particularly through into infancy. This is the BPAC website, just highlighting that to you. They've got a really great, recently updated article there on supplementation of vitamin D and what to do. But again, just highlighting there, we don't have any specialist recommendations around the 50,000 monthly capsule, but we don't consider that this would be unsafe, but it is an unapproved use if you continue it. And then the Perea vitamin D drop is our other preparation. So again, just coming through to here, infancy, the 400 international units of cholecalciferol, 1 drop of the Perea vitamin D to all infants up until at least 1 year of age. And again, I don't think we've communicated this guideline particularly well, so I'll be interested to see what people will have to say. But anecdotally, we're definitely seeing more rickets and hypercalcemia, and we've started screening again through the New Zealand Paediatric Surveillance Unit, and already since October, we've had 27 cases reported so far. So clearly the current advice is not getting through, and hopefully you guys can join with me to help prevent that in future infants. So let's see what happens from there. Just again, advertising the BPAC guideline. It's really good, really nice overview of what to do with testing, but also what to do with supplementation. And again, key takeaways: rickets is definitely occurring in New Zealand, and it should be completely preventable. It's really a very historic disease that we're still seeing on a very regular basis. The universal recommendation now, in line with all the North American partners, is 1 daily drop of vitamin D for all babies, birth to 1 year, and at high-risk groups, in all fairness, you could go much longer. And supplement in pregnancy if they have 1 or more of those risk factors, particularly dark skin, living south of Auckland, social, cultural, or medical factors. So thanks. I think that's all me.
Wonderful. Thank you so much, Ben, for a very succinct presentation. We've certainly started having some questions rolling through, so I'll just present them to you. I think you may have answered this during presentation, but just for further clarification, one person's asked, can you clarify what do you mean by partially breastfed? Is there a volume of formula for partially breastfed? I think you did mention, if an infant has had 1 liter of formula per day, then we don't necessarily have to worry. But do you want to just confirm that, or
yeah, it takes till a reasonably, you've got to get a few months through before you'll get those sort of volumes. So definitely in the first 3 months, basically you're very safe prescribing the drop anyway. Having 400 to 800 units recommended a day could mean you could be on formula at 1 litre with 400 international units and be on the drop and still well be within the safe guideline recommendation as well. So I don't think people need to overthink it too much, but you're talking 3 or 4 months down the track before you're getting to 1 litre or more anyway.
Next question, it's a few parts of this question. So first of all, how long should we be supplementing children with dark skin pigmentation? And does it help reduce eczema/respiratory conditions? I think you did mention to the first year, I guess they're wondering if maybe darker skin could be supplemented for longer than that.
I guess I particularly, and as all of you know, there's been a bit of a backlash against vitamin D being a cure-all. So I've very much focused on the very safe territory of bone health. There is absolutely no doubt that vitamin D is required for healthy bones, particularly in people with open growth plates. But as that case of Mrs. S showed, we're still seeing osteomalacia in dark-skinned individuals in adulthood as well. So, don't overlook that. Um, in terms of going longer, if they've got risk factors, I don't see any reason why you wouldn't go longer. And if they've had rickets before, it essentially means a lifelong treatment. They've proven due to something about themselves, their families, their lifestyles, that they're extremely high risk. But in the South Island, the rates in the South Asian children is incredibly high. I would hazard a guess that we're seeing biochemical rickets maybe in 1 in 10, maybe 1 in 20 of those infants, maybe at least that sort of number. We don't have a survey of that, but it's very high. In terms of those other things, Cameron Grant and team in Auckland did show some interesting data around recurrent infections and potentially with respiratory infections. So there's a little bit of interest in that space, but I think there's enough data purely to protect bones that you can use it, and you may or may not get some secondary gains from that.
So I'll have a follow-up question. So as you said, kind of probably lifelong for anyone who's got rickets. If you're saying maybe it's all right for a bit longer for those other kids, would you want to give us a number? Are we talking till adulthood, to teenagehood, or we love a bit of guidance as GPs?
Yeah, the majority of the hypocalcemia we see is in under 2 and 3-year-olds. So if you thought that they were at least one of those risk factors or more, you're fairly safe territory to go out to that sort of. You'll prevent all the hypocalcemia, all the severe things, the cardiomyopathies, some of the weird things we see. So certainly that first couple of years of life, definitely. And I guess ideally, if we're treating the mothers in pregnancy, then the babies are born with a very good store. They're very correlated maternal levels with infant levels. And again, beautiful data from Auckland showing that. So, it's a good evidence base for that.
Another part to this same person's question, is there a difference between STOS versus daily vitamin D? And my understanding is STOS is talking about intermittent dosing, say monthly or not. Yeah, any difference between those two regimes?
Yeah, well, STOS traditionally is the very, very high doses, say once a year. I'm not a massive fan of that. If you had someone who was extremely high risk and you knew they weren't going to come back, and you knew there would be substantial issues with adherence, STOS therapy is an option. In children, I would very much go away from any guidelines that suggest large doses infrequently. It's much more physiological to give a daily drop. The monthly option is pretty reasonable. That's not technically STOS. That's a different thing. We talk STOS traditionally is giving 300 or 600,000 all in one go. There was some studies where elderly people had a few more falls and some fractures when they were doing that. So I think you should be cautious with those regimens unless you've got a very good reason to use them.
And the attendee also asked, any evidence for loading doses in pregnant women who might be high risk?
Yeah, I think if you've got some time up your sleeve, I don't think you need to load aggressively, particularly if you were going to use the monthly dosing. Where we know it's going to go into stored 25-hydroxyvitamin D. We generally feel the infant and the mother were very well biochemically protected from that. But I can't see any big benefits from big loading doses unless perhaps they're already got osteomalacia, high ALPs, other issues. But you'll catch them up if you're giving them a couple of drops a day right through pregnancy, or getting them on the 50,000. That would be sufficient to give the baby a good start.
In your presentation, you kind of alluded to, rather than testing vitamin D levels, sort of treating the high risk clientele. We've just had a question about, why is that not recommended, actually testing before you treat for anything?
Yeah, I mean, I guess if I own shares in one of the laboratory companies, I'd be telling you definitely to test. There's been a massive spike in testing, as you could well imagine. I think if you feel that someone's at risk, you can pretty safely supplement them, and particularly even just through this 5 or 6 months over winter. You saw that lovely image where if you start someone on vitamin D around April, if they're a bit older, say, than in those first couple of years, you'll protect them really nicely out through to about November, and then they can come off and just get natural UV after that. But you saw that UV image You need about 2 hours of full naked sun exposure in the middle of winter, anywhere in New Zealand to get a daily dose of vitamin D. So unless you're an extremely dedicated naturalist, I don't think that's going to be an option for most of us.
And any comments you want to make about the risk of overdosing on vitamin D or vitamin D hypervitaminosis?
You definitely can. Fortunately, with vitamin D and many vitamins, there's a fairly wide safe range. Certainly at 400 to 800 units daily, you're not going to get into any trouble. If they've got active osteomalacia or active rickets, then doses of 3,000, 5,000 a day over 1 to 2, 3 months are very reasonable to get you back up with adequate stores. But I'm not a massive fan of giving people very supraphysiological doses unless it's part of some sort of very carefully monitored, lifestyle medicine regimen or something. You're treating something with a clear goal in mind. There's not a lot of data supporting regular use of that. You give very high doses to women who are breastfeeding. You can get some to spill out into the milk, but it does require big doses, something like 6,000 units a day, or doses at least 100,000, but probably 100,000 a fortnight if you wanted to do it with intermittent dosing. So again, you can do it, but I can't see why you would want to do that when you can just give them a drop every day.
You did mention in passing during your presentation about Elevit being quite a helpful supplement for pregnant women. But yeah, someone's asked if there's any comments you want to make about other over-the-counter vitamin D supplements, thinking about high-risk ethnicities and if they want to be trying vitamin D for unexplained fatigue they've mentioned in the question. Any thoughts you have about that?
Yeah, well, there's over-the-counter preparations that are often around about 1,000 units a day. Those are absolutely reasonable doses to be taking. You can prescribe Paria to those people, and they'll get it, at a subsidized rate, or the monthly dose. I see no reason for that. I guess I'm not promoting Elevit as such. It's actually extremely expensive at $1 a day. But it would be nice to see some form of supplement like that to be used in pregnancy. If we think the first 1,000 days is the most important time to set our trajectory for life, I would have thought investing in pregnancy and early life with those sort of things would be worth considering, particularly given modern diets.
There's also just a question around, we've talked a little bit about kind of African and South Asian ethnicities. Any comments you want to make about Maru Pacifica children and any risks they're at?
Yeah, they are at lower risk than the South Asian children. The South Asian children, by far and away, are the highest risk. And I think that's a combination of skin pigment, but also, highly educated, often sun avoiding, more modest dress. Um, it, Māori and Pacific children are definitely higher risk than European children, but carry a lower risk than the South Asian children. But in Dunedin, we did a study where we looked at about 120 something babies at 5 months of age, just as part of we did it by accident really, but found there were 3 completely European children with very light skins with very high ALPs and raised PTHs in that biochemical screening, which was just an accident. So that's almost 3% of the randomly selected European babies we examined. So I think there's very real risk out there, no matter what your skin pigment, but particularly in those darker groups.
And I guess following on from what you just commented on, there being some, lighter skinned individuals as well with that sample set. Someone's asked, is there, should we have any concerns about our strong, sun protection message, lathering our kids with sunscreen over summertime? Is there any changes we should be making to that advice, or?
Yeah, we've not gone there. I mean, theoretically, you can use sun for UV. If you're doing that, it should be before 10 in the morning and after 4 in the afternoon. I think with New Zealand's skin cancer burden, we would be unwise to be aggressively promoting that. I think we'll cause more harm than good in the long run, particularly when we have those supplements. We're talking particularly very young children and with very sensitive skin. So very high UV exposure to small children and infants is not going to get you anywhere, in my opinion. Yeah.
And appreciating you are a pediatrician, but someone's mentioned, would you have any recommendations to increase vitamin D for the elderly in aged care facilities?
Yeah, well, if they're in a aged care facility, you've got a few options. They could have the monthly dosing. That would be very reasonable. Or you could use daily supplements, and because you're going to have good engagement with the help you'd have in the facility, that would be another option. But the monthly dosing is probably very reasonable in that group if you know that you're going to be able to access it. And give or take so many days if someone forgets is also a very nice part about the monthly dosing.
Obviously, there's still work to be done, perhaps, in terms of informing primary care about these new guidelines. Someone's asked about whether midwives are being told as well about the recommendations, because obviously they work quite closely with pregnant women. And I suppose there's probably a question about where the responsibilities lie in terms of raising these issues with pregnant women as well. Yeah.
Yeah, I think that's a really great question. I think really we're all in partnership. Normally, when one of these infants turns up to us fitting, they've fallen through multiple potential opportunities to manage them. They've had the pregnant woman well before delivery. You've got the midwife involved. You've got the midwife around delivery, but they've also had their 6-week check with their primary care team. They've had immunizations. There's so many opportunities we could have prevented that 3 or the 4 or the 6-monther from getting rickets and damaging their bones, but presenting with those very more life-threatening presentations. So yeah, normally, I think in partnership, we should all be able to prevent it. Even if one of us forgets, there'll be someone there in the chain who should catch it. What we know is there's no documented cases of rickets in a child in the Northern Hemisphere who's been getting their daily drop of vitamin D. So, as long as you start shortly after birth, unless you basically mum's has osteomalacia and you're born already with rickets, you'll prevent any substantial presentations by starting it straight away after birth.
Also, interesting question about, are there other, say, nutritional deficiencies we should be watching out for in these higher risk individuals? They're kind of thinking about refugees or immigrants. If they're already low in vitamin D, are there other things we should also be screening for at that level of, actually, the ALP is high? Should we be thinking, for example, B12 they've asked? Yeah.
Yeah, well, I think that's a very valid question. And B12 again is a more complex thing for testing and cost, but very much so. We see low iron stores in about a third of these infants presenting with rickets, and I think that goes along often with dietary deficiencies and some of those common diets if they're not managed well. Absolutely possible to have those diets, a culturally appropriate diet that is nutrient rich, but often in the modern world we take shortcuts, and we all know that we run a pretty razor edge, on how we're going with our nutrition.
And on the note of diets, someone's asked, is there any possibility that you could get adequate vitamin D from diet alone?
You theoretically could, but you'd have to be actively chasing products that are known to be supplemented or have been irradiated. Things like mushroom products where you're creating. They've got fungal elements that get irradiated and create ergocalciferol and other options like that. In the Northern Hemisphere, many products are supplemented. So when you buy milk, it often has vitamin D already in it. When you buy bread, you might get vitamin D in it, along with B12 and iron and things like that, folate. So our food chain in New Zealand tends not to be tampered with. And in the Northern Hemisphere, the cheaper products are often the ones that are fortified, which makes a lot of sense because those might be the individuals with the highest risk of nutrient deficiencies. But in New Zealand, we tend to fortify the expensive high-end products. So again, if we're wanting to really help those with the greatest need, diet is going to be challenging.
What's the current advice around giving calcium as well as vitamin D supplement? I know I was taught during my training to avoid calcium supplementation. I don't know if that's changed.
Yeah, as a general rule, vitamin D should be the main thing. There might be certain circumstances where it's very clear the individual's on a low calcium diet. There are certainly situations where calcium supplementation is required, but they're the minority rather than the majority. And some of the studies where high doses of calcium have been given in the elderly and things have had some rather unpleasant, potential outcomes as well, increased cardiovascular risk and other things. So I think you need to have a good reason why you'd supplement with calcium.
In the interest of time, I will move on to our next presenter, but thank you again so much, Ben. Much
Thanks so much.
appreciated.
Thanks all for listening.
Yes.
Thanks. Bye.
Yes, so I will pass on now to Guy, if you can take over the stage for us, please.
Kia ora koutou. Thank you, Plasti. My name is Guy Melrose. I'm an urgent care physician, and I've done a couple of these webinars before where I've tried to find some urgent care presentations that with little subtleties within them that are of benefit to all primary care practitioners, so GPs, physios, osteopaths, whoever's out there seeing, in this case, injuries. So I came across a case that prompted me to look into pelvic and hip trauma. And initially, when I heard of Ben's talk being about vitamin D, that sort of tied it together in my mind, at least. So that's why I stumbled across this particular set of topics to cover in the next 15 minutes quickly. So what I'm hoping to do is to consider occult hip fractures in primary care and to discuss how not to miss them. I want to also consider a common variant in pelvic trauma or related to pelvic trauma that has the potential to be rapidly fatal that we should all know about. And also just have a quick discussion at the end about the use of chest x-ray in primary care for chest trauma and a way to help us consider safe management of older people and maybe not so old people with chest trauma. So that's the objectives. So this is not an occult hip fracture. This is an obvious hip fracture, shortened, externally rotated. This talk is not looking to talk about these. And also, we're not looking at garden classification of hip fractures or any of the different subsets of them, because really for us, these aren't necessary. We're thinking about occult hip fractures. And so I wanted to quickly just present a case that I saw a wee while ago that prompted me to consider and reflect on this topic. And this was a 75-year-old female who had had a fall in a car park not too far from our clinic. And a good Samaritan had seen her on the floor, bundled her up and put her into their car and drove them around to our clinic. And then with the help of our triage nurse, got them into a wheelchair, wheeled through triage and into a room where I saw them. But I was taken by the nurse's comment on the front of the chart that said this patient is unable to walk. Examining, there was no obvious shortening or external rotation. There were no other injuries to find, but she did have a tender hip. And being in an urgent care clinic, I did have x-rays available. So what was the next step that I took from there? And maybe it would surprise you that I didn't do an x-ray. This isn't because I use POCUS. I'm not a POCUS user, and I've not, and I didn't make an error in this case. But the reason I didn't do an x-ray was I chose instead to call orthopedics and also the emergency department. And after discussions with them, they agreed to review this patient in the emergency department. And when I followed the case up, I found out that they had done x-rays that were reported as normal. This patient was then given good analgesia, and physiotherapy was involved with trying to mobilize the patient, and she still couldn't mobilize, so they admitted her to the short stay ward. And the next day, some higher imaging showed an occult neck of femur fracture. And so it was reflecting on this particular case. First of all, I was pleased that I'd kind of made my ground, because at the time, the clinic, there was a $50 surcharge for her x-ray, and I felt good that I didn't put her through that. But also, urgent care x-rays are not like hospital x-rays. We don't have, or at least where I am, we don't have the trolley that you can put the x-ray cassette in. We don't have mobile x-rays. So it would have been a real mission to try and get this lady up onto the plinth, both for the patient and for the staff. And ultimately, it wouldn't have changed the outcome because her x-rays in ED were normal. So this got me thinking about occult fractures. And when I looked for some evidence, I found the Australian and New Zealand Hip Fracture Registry guidelines, and they talk about occult hip fractures being present in approximately 3 to 4% of negative plain films. I have found up to 10% actually in some literature, but they do exist. And and it is something we should be thinking about. And they go on to say that where there is continuing clinical suspicion of a hip fracture, further imaging should be performed, and that can be MRI in first instance, or CT if MRI is not immediately available, or if the patient has issues with MRI. And so when I read this, that prompted me to think, well, what does this actually mean? Continuing clinical suspicion of a hip fracture. So this paper here, I think, is worth reading. The necessity of CT hip scans in the investigation of occult hip fractures from 2021. And this paper looked at 702 CT scans done of hip and pelvis, and 447 of those were done specifically for the suspicion of an occult fracture. So they had negative x-rays, and 256 of those, so that's 57%, did show a fracture. So 1 in 2 of their clinically suspected occult fractures had a positive scan. And interestingly, of those, 24%, so one in 4, had neck of femur, like my lady, and there were 20% pubic rami, 12% of greater trochanter, and there were some other fractures in there. But all of them, interestingly, were not visible on the x-ray. So there was quite a high pickup rate there, significant one, in my opinion, and certainly tallied with the case that I presented there. So looking into the body of their text, they listed these 3 things as being what they would class as clinical suspicion. Pain out of proportion and pain on axial compression are the first 2. And these can be quite subjective. I think, particularly in certain parts of New Zealand, I think we can all think of some, like a Waikato farmer whose pain is probably on a slightly different reference scale to others. And also pain on axial compression is not necessarily an easy test, I find, to confirm, particularly if somebody's fallen onto their bottom. They're going to be bruised and sore anyway, so it's I don't find that particularly useful. But the third one that they said was the inability to weight bear, and this was the thing then when I reflected on this case that I came to realize. It was the nurse's comment that said that this lady's unable to walk, that I think was the thing that made me consider here. This lady had got up in the middle of a car park. She'd got over to somebody else's car. She'd got out of the car at the clinic, got into a chair, had managed to be brought through to a room, up onto a bed. She was mobilizing, albeit with help. And I think for me, the difference here was the difference between inability to weight bear and being mobile. And when I think back, if I'd have done an x-ray on her and it was negative, there might have been a temptation, if she had family support who could put her into a car and take her home, that she might have ended up getting home, and then in the middle of the night, her hip could have completed its fracture, and she could have been in a bad way. So I think my take-home points as it relates to this case was that we really need to be making sure that people who have had trauma to their hip and who present to a GP clinic, to a physio, to an urgent care clinic, somewhere out in primary care anyway, that we make sure that they walk, and that we're not missing a subtle case of an occult hip fracture through them relying on walking aids and being propped up by somebody else. I think we can be lulled into a false sense of security by their degree of mobility. So if they can't actually walk, plus if they've got disproportionate pain and the axial pain, then an occult fracture should be on our mind. And at that point, it's probably better from primary care to be thinking of orthopedics and ED, because an x-ray in the community isn't really going to satisfy us if we have that clinical suspicion. So if you're in general practice, referring them into an urgent care is probably a wasted journey, because if we're still clinically suspicious with a negative x-ray, we're going to refer them on, and we're going to refer them on with an abnormal x-ray as well, potentially. So that does then open the question of, do we do hip x-rays or pelvic x-rays in urgent care? And I think there is a place for that. So if the patient has hip pain but is bearing weight on their hip. Doing an x-ray is good for your reassurance and for the patient's reassurance, and it certainly will enable us to consider discharging this patient with good safety netting to come back if there's any ongoing issues, or ensuring that they've had some physiotherapy, referral, or similar. But we also might actually pick up on some stable fractures that can be managed in the community. And one of the ones obviously is the pubic ramus fracture. I could only find an inferior x-ray example here, but pubic rami fractures are, if they're able to mobilize, can be discharged into the community. But what I wanted to raise for your awareness for my second point is this, the corona mortis, which I only, to be honest with you, became aware of about a year or so ago. This is a variant that apparently is present in up to about 40 or 50% of people. It can be both arterial and venous, or a combination of them, but it involves the obturator artery and the iliac arteries there, forming a kind of an anastomosis that wraps around that superior pubic ramus. And it's called the crown of death, the corona mortis, because you bleed out into your pelvis and can die from it. Orthopedic surgeons are very aware of it when doing hip surgery, and also you see this in more major trauma injuries, but it can occur in minor pubic rami fractures. And so if that superior pubic ramus breaks, it can injure this and result in a negative situation. I mentioned I learned of this a couple of years ago or so. It was Dr. Tim Brabants, who's an urgent care doctor in Hamilton, who drew it to my attention to speak on our podcast. He raised it with me because he'd seen a case of it when he was working in the UK. So we did a chat about that if anyone's interested. But that's how I learned about it. So I figure it's maybe something that we don't all know about. But what is its relevance to primary care? Well, an elderly patient, particularly somebody who's on anticoagulants, who fractures their pubic ramus, particularly the superior pubic ramus, is at risk. Even though it's a common variant, it isn't a common injury, but they are at risk. And so if you see somebody who has this fracture, who has a tachycardia, some abdominal pain, maybe it's becoming hypotensive, late stages, their belly starts to swell and they become quite sick, then we should be thinking of a corona mortis injury. And you might be thinking, well, this isn't really too relevant to primary care. This sounds a bit more trauma, ED. This particular case report here made me pause and think. This is a 70-year-old woman with osteoporosis who had a fall, identified to have pubic rami fractures, and was seen in ED and was discharged after 24 hours of observation in hospital. And it was 72 hours later that she was readmitted with an evolving abdominal mass, hypotension, tachycardia, pallor, etc. And these are treated with embolizing, and but they do, as the name suggests, they can lead to death. So I think it's something that should be somewhere in the back of our minds, so that even though stable pubic rami fractures are mobilized and given pain relief and physiotherapy and managed in primary care out in the community, corona mortis is something we should be considering in older anticoagulated patients with a superior pubic ramus fracture, particularly if they're tachycardic when you first see them, definitely if they have abdominal pain, or if they present to you 2-3 days later in primary care. And at the end of the day, if you're concerned about where the fracture is located, I have found some papers, one that was out of the United States, that was calling for imaging all of these, doing higher imaging to check the corona mortis. So if you've got concern, just asking orthopedics is probably not a bad thing to do if it looks to be close by. And finally, just quickly, some chest trauma, whilst I was thinking about old people and chests. Most severe chest trauma will go to ED, obviously, but the more minor stuff does come to us in general practice, urgent care, and primary care in general, either as a first presentation or as a follow-up. And this is a stat that's been around for years, and I would agree with it. I think 50% of rib fractures don't show on a chest x-ray, so our diagnosis is clinical. And I think we're in danger when I think on this particular topic. I think we're in danger of taking that to mean that we shouldn't be X-raying in chest trauma. What we shouldn't be doing is we shouldn't be doing chest X-rays to diagnose a rib fracture. My colleague at the college, David Sorrell, has a nice saying, and it is to perform chest X-rays for the complications of a rib fracture. And I think if you look at it through that lens, when you're thinking of pneumothoraces for initial presentations and then potentially pneumonias in the later stages, I think when you start to think of it like that, you should be more comfortable in doing chest X-rays in particularly older people if you've got concern. A small hemothorax might not be easy to auscultate. Particularly if somebody's quite sore and aren't ventilating too much. And so I think we need to acknowledge that, yes, we don't do it to diagnose rib fractures. It doesn't mean we don't do a chest X-ray, though. Complications, immediate and late, in the elderly, I didn't have time to go into all the other studies around this, but that there's quite a lot of negative outcomes for people who are treated or maybe undertreated with rib fractures, and some older patients should end up in hospital for analgesic supports, nerve block supports, physiotherapy, etc., to prevent these complications. But I say the elderly, but I wanted to just question whether or not actually we need to move the lens a little bit further back in towards middle age. And the reason for that was I came across this paper, which was out of Northland. It's a local paper in the New Zealand Medical Journal from 2021. And they found, albeit these were only with visible on X-ray rib fractures, which I think is interesting, but they found a higher rate of pneumonia and increased lengths of stay in hospital in patients from 45 and over. And the 45 to 64 cohorts had the same rate as 65 and over. And that made me think that actually, when I think back to the stoical farmer, a middle-aged farmer with a decent chest trauma, yes, you can take a concrete pill and toughen up, but if they've been a heavy smoker or they have some lung disease, maybe we need to be a little bit more cautious about keeping an eye on them and checking in with them and making sure that they're okay and not developing any complication. Something that we can use in primary care that's quick and easy is the Stumble score. Dr. Kerry Battle in Wales came up with this score, and through MD Calc we can easily put in these numbers, and it gives us a percentage of risk of complications from rib fractures. And it's a useful thing for us to gauge this kind of risk potential in our patient. It can help us inform referrals to hospital early. It can help us to decide who do we keep an eye on. And it may be that this patient has been seen in urgent care and a Stumble score was recorded, and it might be in primary general practice that you're then following the patient up. So a Stumble score is quite a quick and easy thing for us to keep an eye on, I think. My take homes, therefore, would be that we should be considering chest X-rays when we suspect a complication of rib fractures, or an early complication or a late complication. And using the Stumble score can help us to risk stratify, to predict the likelihood of some complications. It also helps us to think of things by doing it, such as, are they anticoagulated? Do they have respiratory history, etc.? And it helps us then also discuss with the patient and the family about whether or not you discharge them home, or it helps inform the safety netting and the follow-up and or referral for these patients if they worsen. So I think it's just a case of maybe trying to recognize there is a cohort of people who we do need to be more cautious about. And those are my take homes from there. Just a plug for the college, you can get access to our educational resources via our website if you're not willing or not wanting to go on and do a full fellowship in urgent care. And the aforementioned podcast comes out every week if you're wanting some urgent care educational stuff. And the references there are the papers that I've mentioned.
Thank you for a very interesting presentation. So just going to ask a few questions that have come through. First one is are you aware of any correlation between osteoporosis and these occult fractures that you mentioned?
I didn't. I noted in Dr. Wheeler's, Professor Wheeler's talk that that was mentioned. Vitamin D and and osteoporosis and fractures and the like. So I was starting to go in that direction, but I didn't go into the data. But yes, I think the older and frailer and thinner that your bones are, the less energy is required. And there was that lady I showed that case was an osteoporotic case, and I think most of the older corona mortis ruptures were associated with osteoporosis. So certainly the corona mortis ones were, but it stands to reason that if your bones are thinner, they're more likely to have these little occult fractures that haven't shifted. And I think that's the danger, is that when an occult fracture does then become a full fracture, it's a sudden event similar to when it initially breaks, your hip suddenly shortens, externally rotates, and you're in a lot of pain and discomfort. And my fear is that we could miss those ones if we're not mobilizing them properly in front of us. We're maybe saying, oh yeah, they got in here okay, they can get about. We do it with ankles maybe, we expect people to limp, we expect people to hop, but I think with the hip it's more important that we actually get them to put the weight through it. And 65, 70 or over lower threshold, or to speak to the hospital to say, look, should we be higher imaging these patients?
Cool. And then on the topic of, I guess, mobilization, as you said, that's one of the things that we should be looking for. Can they actually sit properly mobilized before we send them on their way? Any advice you have on what kind of an analgesia we should be giving these patients first to help them feel comfortable and then safely assess their mobility?
Yeah, so that's an interesting one. And I, again, didn't have time to mention it in the body of the talk, but with my lady, we did discuss within, with the patient, with the nurse involved, the idea of, do we give her something stronger? She couldn't have anti-inflammatories because of her age and other risk factors. So really we were limited to paracetamol, codeine. I don't like giving tramadol in anyone really, but older people in particular. So do we give them a little trickle of opiates intravenously? And then you think, well, we're in primary care. What position am I to observe this lady? And then if she's requiring that to mobilize, is that actually a bad sign? So we actually came down, and this was part of the discussion with the hospital, was saying, look, I could maybe make her more comfortable, but is that safe for me to then do that and discharge her home? And so it was making what I'm always trying to think of is it's not what can you do, but what should you do? And I think in primary care, urgent care, we should be thinking like the cost of the x-ray for the patient, how, yes, we could give her some fentanyl and put her on the bed in our x-ray, which would make her more comfortable, but then where am I next? I've got an old lady on opiates who's got a negative x-ray but still has maybe an occult fracture suspected. So I would personally use paracetamol and codeine, and anything more than that, A, is telling me they need more, therefore there's something more serious, and B, has complications that mean I wouldn't want to give it to them anyway, if that makes sense.
Next question is around chest trauma and if and when you would re-X-ray. So, if you have chest trauma and initial X-ray doesn't show a fracture, but they have ongoing pain, when would it be an all right idea to re-X-ray? Is there any value to doing repeat chest X-ray? And what interval would you wait until before X-raying again?
So my understanding and my practice would be always x-ray for the complication, not for the rib fracture. And you will then see a rib fracture possibly, but not always. And I guess the longer you leave it between the injury and the next x-ray, you might then see signs of a healing fracture, and so that the incidence may go up then. But I think the difference is hemothorax and pneumothorax on day 1, 2, 3 will present with, you'll have auscultation problems in the apex for a pneumothoraces, and more of a dull base for hemothoraces. And if you've got POCUS in your clinic, that's a very good way of excluding these things as well, which I don't think I mentioned. But so you're doing it for that then. But the later stages is obviously people are developing they've been hypoventilating and they've developed pneumonia or kind of I guess empyemas and these sorts of things. So your clinical picture might be will still guide your decision making. But I guess if you did a chest X-ray on day 1 and there wasn't anything, and maybe their reduced air entry was just because they were sore, week 3, 4, and they're coming in with shortness of breath and you can't hear much in the base, you're X-raying to look for pneumonia and other changes. So yeah, repeat X-rays probably sensible, but not to look for healing fractures, is my understanding, because it's a clinical decision still. You press each rib, and if they say ow appropriately, then you say, yeah, it was probably a rib fracture. And if they are better after 2 weeks, then it wasn't a rib fracture, it was a bruised rib. But you treat them the same in terms of ventilation advice and pain relief and close observation for fever, hemoptysis, productive cough, pleuritic pain that's different to their rib fracture pain and all of that kind of stuff. So yeah.
Great. Thank you so much, Guy. We will move on now to Christine for our update. Thank you, Christine.
Thank you. I'm presenting on behalf of Sue Tutty, who's away on some well-deserved leave. She's given me a pretty steep task of 26 slides in a very few minutes. So my aim with this is really just to alert you to some of the sector changes, some of the things that are changing around medications and so forth. So it's a whirlwind tour. But just to re-alert you to the concern around the HIV in Fiji. I know that this was mentioned in the February webinar, but it's really important that we're aware of it. Just for those that were unaware, that from January to September 2024, there were 1,093 cases, or new cases of HIV diagnosed in Fiji, and 51% of those cases were in 20 to 29-year-olds. So it's really important in primary care that we're thinking about this, particularly and especially pregnant women, and always considering it when we're doing STI screens. So please just have an added awareness of this in the community at the moment. Just to let you know, from a health pathways update point of view, there's quite a bit of work going on in the immunisation health pathways, and you will find some really good information on the influenza immunisation. Everything that you really need for the current campaign is on these pages in the health pathways, and so do dive into that if you have any questions about that. It's a really nice way of concisely summarising everything that you need to know in one space. Also recognise that there's new pages on vaccination resources, and there is so there's some really good additional resources there that have been updated in the recent month. And for example, where to find the new schedules, any updates, thinking about those special groups to vaccinate, and any special situations. So just alerting you to those health pathways pages. And particularly also to immunisation contacts. There's a lot of activity on immunisation. People are very aware of the 24-month immunisation target, and we're coming into Q4 for that. So this is really important to have your contacts. There's been a lot of work happening in primary care on improving that data to the Aotearoa Immunisation Register. That data is improving greatly. And this will also, in your local health pathways context, provide you with the local information for those people who are immunisation providers in your local community. And any questions that you might have, for example, for the air admin teams, you can find the information on this page. The other health pathway that I've been asked to alert you to is the new health pathway for urological postoperative complications. Apparently, this page is receiving a huge number of hits from primary care, suggesting that it has been a very useful new addition to the health pathways suite. And these are the types of urologic procedures that it covers. And these are the common problems that occur, and presumably are the reasons why people are looking into this health pathway. So just to let you know that health pathway is there. Some updates from Pharmac. There are a number of changes that are happening. Just to note that Series Z funding is available from April. You should have noticed already that Salazarel has now been stopped. Champix is now again on relisted. as of the 1st of April. And there are ongoing issues with methylphenidate, and you will, particularly if you're in the northern region, I know certainly that we've provided updates through Medins on methylphenidate and the updates that have occurred around special authority updates where Pharmac have widened the special authorities and also created the second special authority for many of our patients who are on methylphenidate prescriptions to ease the ability to move between different preparations depending on supply. So look, there is good information on Pharmac, but also health pathways to support you with any of those issues around that. Just to note about some ultrapox supply issues, and it looks like it's going to be increasingly difficult to source those ultrapox medicines, and you need to look at options of alternatives. Another one, dipyridinol, is no longer going to be supplied, and the key dates for this is clearly it would be worthwhile looking through your patient list for anybody on these medicines and making changes ahead of time. And obviously do not start any new patients on these tablets. And look, there's some really good information on the Pharmac site about other options to consider, particularly, for example, other options on the New Zealand formulary. So that would be really good to have a look at for any of your patients on dipyridinol. Let me move on. Right, there's a whole lot of changes that have occurred last year and this year around insulin provision, and just really to update you that the Rhizodeg, which I presume is how it's said, may be a suitable replacement for the Novo mix, but just be aware that there are a series of changes happening to that will be affecting any of your patients on these insulin preparations. And also the discontinuation of these insulin preparations. So obviously being aware of that and looking at the up-to-date information on that. Sue was very helpfully here provide the equivalent insulins, and those equivalents have also, you can find links for that on the health pathways. Again, use just some more information there on the insulins. Also to be aware of some contraception proposals that have gone through in Pharmac, proposal for Mariana and JDS to be funded on a practitioner supply order, and making that with the intention of making it faster and easier to access these. Also, Pharmac's proposing to increase the number that are available on practitioner supply orders. So that would really assist any clinics who are providing those services. So the consultation for these closed on the 25th of April, and if those are approved, the changes will start on the 1st of July. So I'm sure we'll all look forward to those changes and hope that goes through. Looking forward, there's been a number of announcements regarding primary care. This is really a bit of a snapshot, and I think that there will be additional detail to this coming through in the following weeks and months, and really looking to expand the opportunities of delivering primary care with a wider primary care team, and I think that we'll have a lot more detail about this, and you'll be able to get that from your PHOs and other communications. Again, more opportunities around increasing the workforce, a lot of focus on getting doctors through the international pathways, and also around improving retention or recruitment and retention of our new graduate nurses into the primary care fields. Also, the primary care funding boost around, but being tied to key indicators. So really looking for those quality improvements in primary care around things like being able to have open books, shorter wait times, longer opening hours, and improved information sharing, including with the hospitals. So I think that is all being formulated at the moment, and there'll be increasing amount of detail coming out about that in the next weeks and months. Okay, just some other things that are dear to our heart. There's a lot of, particularly Sue, who's done a lot of work on the abnormal bleeding pathways and done a lot to implement, particularly in counties Manukau, great primary care pathways for improving access and earlier diagnosis in the community. But also a real increase in interest in delivering a lot more of these pathways in primary care. So this is a lot of the pieces of work that we're busy on in Health New Zealand at the moment, developing up how we can do this in a more whānau-centric way in the community, and ensuring primary care is supported to provide these services. Okay, I think that is almost the end of the whirlwind tour.
Thank you so much, Christine. I'm aware that we have reached the end of time as well anyway today, so I think we'll wrap things up there. So I just do want to extend a big thank you to Christine, Guy, and to Ben as well. Ben has had to leave a little bit early, but it was an excellent talk nonetheless. And thank you to our attendees as well for your engagement and asking lots of very interesting questions. So thank you again very much to all our attendees and our speakers, and we'll see you again at our next webinar. Thank you so much.